Hi, everybody, and welcome to our second lecture. Our second lecture is called Collaborative Drug Therapy Management Agreements and Billing Opportunities for Clinical Services in Community Pharmacy. Once again, just putting out the disclosure that this lecture I have no actual potential conflicts of interest in relationship to the presentation. So if you remember in the first lecture, we talked about clinical opportunities, we talked about value-based healthcare, and we talked about different ways we could start thinking about how we can put different types of services into our community pharmacy. One of those types of services that we talked about is collaborative drug therapy management. So during this talk, we're going to talk about a couple of different things. We're going to talk about what actually is drug therapy management. We're going to identify the key components in a written collaborative drug therapy management agreement. We're going to review the key steps to getting started with a physician-pharmacist collaborative drug therapy management agreement. And we're going to discuss some, examples of where you can find resources for that. And finally, we're going to talk about some opportunities in billing. So, as in the prior lecture, it's not always easy to look at what does the future lie. One of the things in my past experiences I remember, and this was 1996, and I was in the midst of obtaining my post PharmD at the University of Pittsburgh, and I did several rotations up at the VA hospital in Oakland. And during that time period, the VA itself actually had physician pharmacist collaborative practice agreements. And I was able to participate in 3 of those different clinics. One of those clinics was actually an anticoagulation clinic where the physician wrote the prescription for the warfarin, diagnosed the patient that they needed warfarin, and the patient would either initially, the first time I did it, they actually had to go to the lab in the morning, get their INR drawn, and then we would see them in a consult and basically do an evaluation whether or not they needed dose adjustments. We would also assess any drug interactions, any dietary things. The second time I was there in the anti-coag clinic, we actually were able to have a Coagucheck machine and were able to make adjustments based on. And we had certain guidelines with that. And I'll explain that a little bit further when we get into detail about a collaborative practice agreement. The other 2 clinics that I got to participate was a hypertension clinic and also a diabetes clinic. In both those clinics, we were able to do dose adjustments, do physical assessments on the various medications that are used in hypertension and diabetes. And so if you think back, that's 21 years ago, and it's 2017, and we're still talking about how can we have collaborative practice agreements in the community setting. And sometimes you scratch your head because the one thing, there's lots of things that you can knock the VA system for, but the one thing the VA system, including Kaiser Permanente HMO, has done, they've really embraced pharmacy and recognizing pharmacy as a resource in being able to do these type of collaborative management agreements. So it's not like these in the last couple of years have just been created. They've actually existed in several different entities, but now we're seeing through laws passed by state pharmacy acts that we can actually apply this within hopefully outpatient practice. So as we know, there's lots of community pharmacies, lots of pharmacists here in the United States. We also stated in the prior lecture that most patients visit their pharmacy more often than any other healthcare provider. We also realize that we're not always used to our best potentials, to our most potentials, I guess. Not to our best, but to our most. And unfortunately, a lot of times there isn't a great communication pattern that we can directly contact the physician. So the question always is, how can we develop a patient-centered system that utilizes the resources and expertise of us as pharmacists to be part of the members of a healthcare team? Remember in the prior lecture, we talked about how we can contribute to both clinical, humanistic, and economic outcomes for a patient. So, how do we do this? We talked about hopefully maybe down the road being able to access provider status that would define those roles, especially under Medicare medical benefits side. We also have to think about how do we incorporate these things without disrupting not just our workflow at our setting, but changing workflow patterns at hospitals, healthcare institutions, outpatient physician clinics. So basically, what a collaborative drug therapy management program is putting a connection. Think about this. When a patient goes to the physician, a lot of times, even despite electronic health records, the physician does not always know everything the patient is taking. Or do they know how adherent are they to those medications? What over the counter medications they take? The physician writes a prescription, and the physician, especially physicians who've graduated in the last several years, don't get the pharmacology, don't get the drug expertise experience that we do under our curriculum. The patient who then goes to the pharmacy, and where is the pharmacy lacking? The pharmacy is lacking that we don't have the data all the times. We don't know what their true diagnosis is. We don't know what their labs are. We don't know, what, the progress notes of the physician. So a lot of times we're doing counseling and trying to do maybe a Marexin MTM without a little bit of knowledge. What the collaborative drug therapy management agreement really does, it helps develop a clinical contract that we can definitely start sharing information back and forth with each other with the ultimate goal to take care of that patient. So, what a collaborative practice agreement is, it is a formal practice relationship between a pharmacist and other healthcare practitioners, whereby the pharmacist assumes responsibility for specific patient functions that are otherwise beyond their typical scope of practice. And so the physician is able to go and, you know, based on agreement of protocols stating what is the pharmacist able to do based upon our education and training. Think about immunization. Immunization actually is a collaborative practice agreement. Many of you utilize the collaborative practice agreement that Value has through Dr. Zane Gates, but there's other, maybe you've contracted with your local physician. That essential is a collaborative practice agreement. But a collaborative practice agreement can go on be just being able to immunize. Here in Pennsylvania, and like I said, I'm not attuned to all laws in other states, but specifically in Pennsylvania, over the last several years, over the last decade here, we've really pushed for this physician pharmacist collaborative management agreement. And even though this is now in our Pharmacy Act, we don't probably haven't utilized it to its best of its potential. A lot of times, if you approach a physician about this, they're not even aware that this could occur. And so, what I hope today in this talk is to identify what are those components, identify how do you approach a physician, why would they want to use you in a physician collaborative practice, because we're always looking for that win-win, and what are some opportunities down the road for financial opportunities for us to be reimbursed to justify this collaborative practice agreement. So, lots of different states have been successful in developing innovative pharmacy patient care services. We're aware that California actually has been able to get provider status. So, as the state of Washington, instead of the state of Washington actually went even beyond that, they are able to recognize that almost they have to be recognized by all types of insurances for billing. And so, lots of different states have tried different entities that go along with this. Most of these collaborative practice agreements still fall under that standardization that I talked about in the first talk of the pharmacy care process, which is the MTM process. So no matter what disease state collaborative practice you might be looking to get into, anticoagulation like I mentioned, diabetes, hypertension, those steps that you are going to do as a pharmacist still fall under that same care process of MTM. We have traditionally always been more product focused than clinical focused. But if you think about, basically, we've been doing clinical probably forever. We just don't realize that. Because clinical focus is being patient focused, is helping evaluate that patient's drug regimen, individualize it, making sure the patient's being monitored appropriately, making sure the patient is being treated appropriately, and seeking positive outcomes for their disease states. Numerous studies have shown the benefits of clinical pharmacy services. They help improve outcomes, reduce costs, improve patient access, improve efficiency of medical providers, improve quality of prescribing, patient satisfaction, and improve patient knowledge. Clinical pharmacy services, through various studies that have been published not just in pharmacy journals but in medical journals, have shown that when you incorporate a pharmacist into a clinical care team, that pharmacist, with their knowledge about medications, has been shown to be able to decrease adverse drug events, prevent med errors, improve medication adherence, drug knowledge, not just to the patient, but to the entire care team, which in turn improves outcome by improving prescribing and making sure that medications are selected on appropriate use. Not just the medication is the right medication for that disease state, but is the right medication for that patient based upon maybe their, kinetic factors and pharmacodynamic factors. And clinical pharmacy services, if we look at the institutional setting, have definitely shown that they can help in shorten lengthening of hospital stay, which we know that our hospitals, the way they get paid a per diem per day, based on DRG codes, and those are reflective that, if the patient stays longer than they should, then the hospital is in the red versus in the black. The question always remains when we think about collaborative practice, are we stepping on other people's toes? I can remember back, and maybe you do too, in the early 90s when one of the terms we used to use was prescriptive authority. And I can remember, I think it might have been on an NBC News evening where Tom Brokaw broke out to a story that was being covered about, I think it might have been Mississippi, looking for prescriptive authority and looking at this old Mississippi physician that kind of looked like the physician from Forrest Gump, and talking about pharmacists had no right to be doing that. But I think we've gotten smarter in terms of how we use terminology, because really what we want to be able to do is practice what our skills are. And our skills is we're the drug expert. We understand about when's the best time for that medication to take, to evaluate whether or not the person's using it appropriately, whether or not they can crush it or not crush it, whether or not they is the right drug for the right disease state based upon what the evidence-based medicine is out there. And pharmacists are not stepping on toes of nurses, physician assistants, but they're helping enhance the process. Anytime you bring in an expert who is more of an expert in that field, ultimately, hopefully, provides better outcome. When we look at all the different states, and this has grown, we have pretty much every state does immunization. But when you look at collaborative drug therapy management that I'm going to be talking about in turns, is that we have close to 48 states. Alabama is working very hard, and so is Oklahoma, in pushing for some type of collaborative practice. Even the state of New York has a collaborative practice agreement. Some of these are very limited in scope, but really what drives all of these is the development of that MTM process. So, in turn, the collaborative practice agreement is an extent of services authorized. Once again, though, because you probably have read the Provider Status Act, it still comes down to the state's statutory and regulatory provisions that give this authority. And so I know that the National Association of State Pharmacy Associations is trying to develop standardizations for collaborative practice, but it still comes down to individual states of what is our scope of practice. And the other thing is, a collaborative practice agreement are the terms of a specific agreement between the pharmacist and the other healthcare practitioner. So there is latitude of what we're allowed to do under the Pharmacy Act, but it still comes down to the healthcare practitioner, that physician, how he or she feels comfortable of what privileges they plan to give us in that collaborative practice agreement. So, as I said, 50 states, 50 sets of rules. States have taken different approaches to collaborative practice agreements, including practitioners able to participate in them, the services that may be provided, what services can be provided under these, logistical barriers that limit the utility of such agreements. And a lot of times, states don't consistently use the same language when describing these when it comes to protocols and collaborative drug therapy management. I think a big push, and I mentioned this in the prior talk, is that in 2015, the National Governors Association put out a paper stating that there needs to be an expansion role of pharmacists, realizing that pharmacists have the expertise and able to help meet some of those needs in our, you know, everlasting growing and cost growing healthcare system. And we need to look at how can collaborative practice agreements possibly move this along faster as we wait for things such as provider status. NASPA, as I said, the National Legions of State Pharmacy Association, had developed a work group several years ago in helping develop some guiding principles that what needs to be done. And when you're developing a collaborative practice, I'm going to share you some resources, and I think both NASPA and our own state pharmacy association actually has a toolkit. We actually have a toolkit on our PPA website that helps guide you and gives you examples of what collaborative practice agreements are. The other thing too, by having some standardization, hopefully it will help, protect against, making sure we're getting good patient care, but also help us from a liability standpoint. So a collaborative practice agreement, as I said before, is an agreement between one or two more physicians and pharmacists. Under this agreement, there is a defined protocol that the physician is delegating to the pharmacist specific professional responsibilities for certain drug therapy tasks. This usually has to be reviewed and approved by appropriate bodies. And depending upon where you're working, that institution, that health system, if it's a health system owned physician group, they may have to improve it internally. If you're doing an institutional, it may have to be approved by their P&T committee or the executive board. But here in Pennsylvania, all the collaborative practice agreements need to be submitted and to the State Board of Pharmacy. What goes into a collaborative drug therapy management? What tasks are we giving? I'll go into some specific tasks of what the Pharmacy Act says here in Pennsylvania, but other states can be a little bit more liberal of what they're allowed to do. Like the one thing I remember working in the VA system way back when, under the hypertension and diabetes clinic, we were actually able to initiate new drugs, whereas under our collaborative practice and our Pharmacy Act, we're only allowed to adjust doses of drugs that have already been prescribed. So, collaborative drug therapy tasks include performing patient assessments, so doing things such as blood pressures, doing lab checks like anti-coag checks, hyperlipidemia, cholesterol, point of care testing. I talked earlier in the first lecture about point of care testing. Point of care testing would require a collaborative drug therapy management agreement. If you get into telemedicine or genetic testing, would require that, because that in turn gives you the authority for certain patient assessments like a buccal swab, collecting nasal droplets, doing a strep throat swab. The other thing a collaborative therapy management agreement does is allows us to order and evaluate drug-related therapy tests. So if I'm doing an anti-coag clinic, this agreement gives me the authority to order things such as an INR. If I'm doing, a rheumatoid arthritis clinic, I may be able to order a SED rate, depending upon the drugs, order liver function tests, order a Chem7 if I'm evaluating somebody's renal function or their electrolytes. The other thing is a collaborative practice allows us to select, initiate, monitor, and continue adjusting drug regimens within a protocol. I'm going to go back to use that example of that anti-coag clinic, that within that anti-coag clinic, within that protocol, we were allowed to up and reduce the warfarin dose within a certain range of where that INR lied. If that INR was above a significant range, I believe it was 6, or if it was below a significant range, I believe it was 1.4, then we needed to contact the physician immediately, and they had to evaluate what they wanted to do, whether they needed to do bridge gap therapy with low molecular weight heparin or heparin itself, or if it's a high INR, whether or not vitamin K was warranted. The other thing, collaborative therapy allows you to maybe do follow-up visits to evaluate patient response. It gives you counseling and education authority. And as we do here in Pennsylvania, it gives us the ability to administer medications. And not necessarily it always has to be an immunization. Another opportunity may allow you to do vitamin B12 shots, may allow you to do antipsychotic, depot injections. And so a collaborative therapy agreement can give you numerous ranges. So let's identify the key components in a written collaborative drug therapy management agreement and what do they say. So our original collaborative agreement was passed in 2002. And in 2002, look how old this is. We got Governor Mark Schweiker, but remember that was when Tom Ridge had left for the Secretary of Homeland Security. And anyways, when this was passed, it was passed for institutional settings, which included hospitals, nursing homes. And when that act was passed, it was the very first time anything had been done to the Pharmacy Act since 1961. So basically, as I said, that original act, which still exists today in the Pharmacy Act here in PA, that allows a collaborative practice agreement in extended care facilities, nursing homes, nursing care facilities, resident care facilities, hospitals, and so forth. So you could have a collaborative practice agreement with a nursing home that you take care of. Maybe you develop an anti-coag clinic or a diabetes clinic, or maybe you are allowed to order certain labs under a collaborative practice that you don't have to do those as your regular note saying, "Dear doctor, please order these labs." You could order those labs yourself and then be able to evaluate therapy and go on and give recommendations. The initial act gave these duties here in Pennsylvania. It allowed us to adjust a drug regimen, adjust a drug strength, adjust a frequency of administration or route, administer drugs, order lab tests, ordering and performing other diagnostic tests necessary in the management of drug therapy. Notice in ours, it did not state that we're allowed to initiate, and it still says we're not allowed to initiate. A couple other key things in this act is that this act is a written document. It needs to describe the nature and the scope of the drug therapy management to be carried out. And I'm going into a lot of detail of this. And when I get to the outpatient one, nothing really changed much. It kind of stayed the same. So what I read here is pretty much what the non-institutional collaborative agreement is. The agreement is the new rules mandate not only there be a written agreement between a licensed physician and pharmacist, but also what must be included is that this cannot exceed 2 years from the date of execution. It has to be renewed. It must contain, among other requirements, a provision that drug therapy regimens be initiated by a licensed physician and a provision detailing whatever we do in dose adjustments or whatever that the protocol states, we have to notify the physician not to exceed 72 hours when there's any changes that occur. There has to be a statement in the collaborative identifying the types of drug therapy management decisions that the pharmacist is authorized to make, including a statement of ailments or diseases involved within the physician's scope of practice. So whatever the physician gives us, that physician also has to have that within their scope of practice. The signatures of the licensed physician and licensed pharmacist are entering into the written protocol and the date signed, submitted, and needed to be recorded with the State Board of Pharmacy. So let's look at the non-institutional. The non-institutional was passed in 2010 and took several years for the regulations to, finally to be written and to be posted. But the non-institutional setting says the following. The management of drug therapy is any of the following, and it really hasn't changed. Adjusting a drug regimen, adjusting a drug strength, frequency, or administration or route, administering of drugs, ordering lab tests, monitoring patient vital signs, providing education and training to the patient which is related to the management of drug therapy. think about even the education and training, because I'll bring back that. The written protocol needs between a licensed physician and pharmacist and shall contain a statement identifying the physician responsible for authorizing it, a statement identifying the pharmacist who is authorized for this, a statement requiring that the drug therapy regimens be initiated by a licensed physician for a patient referred to a pharmacist, a statement identifying the types of drug therapy management decisions that the pharmacist is authorized to do. Within this written protocol between the licensed physician and pharmacist, a statement of the functions and tasks the pharmacist shall follow in the course of exercising the collaborative agreement, including how these methods of what we do is documented, the decisions made, and how we communicate this back to the physician. Once again, we need to show that we are going to relay that information to the physician no later than 72 hours. And so, what is the communication process for that to occur? There also should be a statement that requires notification to the authorizing physician of any changes, and like I said, of no longer than 72 hours. The other thing is there should be a provision for execution of the agreement when the licensed physician or the licensed pharmacist may be temporarily absent from the practice setting. So you can have a collaborative practice agreement that may have numerous physicians and numerous pharmacists, but each one of them has to be in that agreement, has to have their signatures in that agreement. They must notify the patient in writing that there is a collaborative drug therapy management agreement, so there needs to be a consent that the patient is aware that this is occurring. And there has to be signatures of all parties involved. This protocol has to be available at both practice sites if they're not practicing in the same place. The written protocol must be filed with the borough, okay, and must be effective for a period not to exceed 2 years. A statement allowing for termination agreement at the request of any party to do it at any time. So you're not allowed to write like a contract of a 60-day out. This agreement can be null and void at any time either party wishes to get out. Some additional points, like I said, it must be a written agreement. Both physician and pharmacist have to be licensed in the state of Pennsylvania. A pharmacist may not provide economic incentives to the licensed physician for the purpose of entering into the agreement. Now, I'm going to talk about billing later, but this is an incentive. So once again, you're not allowed to, maybe give kickback based on prescriptions you fill, things like that. Definitely. The other thing is the pharmacist who is employed by the physician pursuant to a collaborative agreement for the purpose of the management of the drug therapy shall not engage in retail dispensing while in the healthcare practice within the context of such employment. So if the collaborative practice agreement has you going to visit that physician maybe once a week or twice a week, that you're not able to be dispensing at the same time. Once again, this is a voluntary agreement. Some additional points. Pharmacists must utilize for in-person, telephonic, or other approved electronic consultation related to the management of drug therapy that ensures confidentiality of the patient information being discussed. The one important thing about this collaborative agreement, if you think about it, it is a contract. And so one thing that contract does is allows that those patients that are those of the physician are your patients that you're taking care of too. So you are there should be a business associate, my personal opinion, a HIPAA business associate between the two parties to make sure that HIPAA is being complied with, and those all have to be taken to play. If there's any communication between the physician and the pharmacist, well, once again, we need to follow the HIPAA electronic, regulations. But what this may do, though, a collaborative agreement, it may allow you to have possible access, passwords, maybe interface with that practice someday from your system. Patient records related to the management of drug therapy must be maintained in a computerized record-keeping system, which meets all federal and state regulations. And so, once again, whatever documentation your system you're using, you want to make sure that it's complying, that it's HIPAA compliant. The other key thing that is required both in the institutional and non-institutional, that a licensee who's a party of the collaborative drug therapy maintain a level of insurance coverage of a minimum of $1 million per occurrence claim, and that has to be stated within the agreement. So We talked about the key components. We talked about what a collaborative drug therapy management agreement is. Let's review the key steps to getting started with a physician-pharmacist collaborative drug therapy management agreement. The process getting started. So, first off, you find a physician or the physician finds a pharmacist. I stated in the prior talk that some of the key places that I think or key physicians to find are those who are still private practice. A lot of those physicians share a lot of our commonalities as independent pharmacists. And like I said, the successes that I have found have been with that, or smaller institutions that are not able to fight against some of the biggies that we know that exist in our state. You may need to share with that physician or put together maybe like a business plan presentation, and you may need to show them what your past training is, what are your certificates, or maybe who your employees that you've hired. When you are looking to get into this, if you don't feel comfortable that maybe you have the skills to do that, I can share with you that I know in the school of pharmacy that I teach in, I know that in several of the other schools that I know across the state, that collaborative practice agreements, how to get those started, and trainingship is discussed in the curriculum. The other thing is too that some of these pharmacists that are coming out of residency training programs, certificate programs, and these are things too. There's lots of great certificate programs that if you want to be the pharmacist who's doing the collaborative practice and the clinical training, that there's lots of opportunities. And I extend out there that your associations, both your state associations and your national associations that support independent community pharmacy, offer some very well certificate programs. Because you may need to demonstrate to that physician that you're trying to partner with that you possess the knowledge or you have the staff who has that knowledge to manage certain disease states. It is a development of comfortality that that physician realizes you're treating that patient just like it's your very own. All right. One of the things I always suggest is when you're calling a physician and you're calling them about maybe just a problem of a prescription you're filling, communicate with them. Hey, I was discussing with our mutual patient, Mrs. Jones. Let them know how much you care about their patients and the outcomes that they reach. Other opportunities, you may look for certifications on our Board of Pharmaceutical Specialties. You may get into diabetes, asthma. Think about what credentials you may want or you may think you need, which will also provide you additional education to be able to take on this collaborative practice agreement. So, like in any business plan, we identify a need. Maybe one of the things when we first started working with one of our physicians is we just went out and had dinner. Sometimes too, going to non-pharmacy associations, maybe going to your local community groups in the area, the Rotary Club. Where does the physician go? Maybe putting out a survey to physicians within a practice. What are their needs? What are they struggling with? Because one of the things that they're struggling with that there's a commonality is they got to meet all these different quality measures too. And a lot of these quality measures are tied to medications and medication outcomes. How are they handling high-risk patients? How are they handling costly disease states? So all of these things help identify that need. And when you're trying to pick what type of collaborative practice agreement should I do with this physician, you want to discuss with them and find out what is that? What is your passion? Maybe you have a real strong passion for diabetes or for heart failure or for, rheumatoid arthritis. And so pick a disease state if you want to start a collaborative agreement that is something that your patients need that are coming to your pharmacy and that you feel that physician. A real quick way to do that is we all can run a report in our pharmacy system. Who's our top prescribers? Determine the focus of your service. So maybe do a needs assessment to decide what will the service be offered. Do some research. I know that a lot of you, it's been, maybe several years that you've not been in school, but let me share, if you haven't, obviously we can Google something, we know how to search on the internet, but there's one thing that Google offers. It's what's called Google Scholar. And if you never use Google Scholar actually ties into Medline. And you can actually do and look and research and find out what studies have been out there, what is out there to show that this is a need. All right, you know, other considerations you need to think about is analyze your own patient population. What disease states are you taking care of with the patients that come into your store? What are your top 200 prescriptions you're filling? What is the expertise of your staff? Do you need to send them to more training? So do a good needs assessment of what need to be done before it starts. The other thing is build support for your service. Identify practice champions. Maybe go visit other places that are doing collaborative practice agreements. Start building those relationships with key people. It's not just the physician, even though they're the ones who can give you the authority, but getting to know the people in that physician's practice, such as the nurses, the billing specialists, the lab personnel. You want to share with them that if you're going to be doing this collaborative practice, that you're not just, you don't want to get into like it's a turf battle. Is this person coming in to possibly take my job? No. This person, your service, is coming in to help enhance what they do, maybe take some of the burden off what they do, and ultimately allow them to meet the measures they need for their patients. The other thing is some of your services may be patient needed. Patients looking for somebody that's providing diabetes education, more education in certain disease states. And so maybe you need to survey your patients and see what they're looking for. So let's look at some examples of successes that have been out there, in the studies that you can pull when you're trying to market this to other places. There's numerous supporting evidence. I talked about the VA system. The VA system has been doing collaborative practice type agreements all the way since the early 1990s. And so has the Indian Health Service, so has most all of our armed services. North Carolina, I talked about their enhanced pharmacy service network. They're doing a lot of this with clinical pharmacist collaborative practice agreements. Maryland has done something very similar with drug therapy management in their state. A key thing too to think about when you go to talk to a physician, we all know how we make money, or sometimes unfortunately we may lose money when we fill a prescription. But how does a physician make money in the outpatient practice? They are being told with cuts possibly with Medicare, and also looking at what's called pay for performance, just like we are, that no longer do they want to pay a physician fee for service. And so some of the agreements, if you read of what's occurred, is that they necessarily have not done cuts to physician reimbursements, but if they wish to see increases in reimbursement, it's with, are they meeting certain goals and certain, and so basically it is a pay for performance. And a lot of the things that they need to do to get that extra incentive is based on how well they are controlling the disease states of their patients. And so why do we care? Well, I'll give you some stats out there. 15 to 24% of hypertensives are controlled. The remaining are not. 42% of diabetics have controlled lipid levels. Greater than 50% are not. 35% of eligible patients with AFib don't receive appropriate anticoagulation. And even though some people may think warfarin's going away, guess what? There's a lot of criteria of what makes somebody to be put onto a direct thrombin inhibitor. And these drugs are expensive, and the expense of somebody being hospitalized for a stroke, for a significant bleed. A majority of CHF patients are readmitted within less than 120 days. Hospitals are penalized if patients like CHF patients, COPD patients are, readmitted in less than 30 days. A lot of hospitals run physician practices, and so they may be looking for somebody to play that intermediate between discharge and that first physician visit. And that's why transitions of care has been a growing market for pharmacies to get into. Physicians a lot of times have to meet these different goals, and they meet these different goals with measures called HEDIS measures, all right? And so some of those quality goals may be in areas of that they're using their electronic medical record. What is the adherence, of their hemoglobin A1C every 3 months for patients with diabetes? and how many of their patients are less than 7% in their hemoglobin A1C. So if you're not familiar with the HEDIS measures, you can access those online. And the HEDIS measures, although they are initially are health plan measures, those trickle down to physicians just like the star ratings trickle down to us. I did a project a couple years ago. I had a student take the HEDIS measures, and we found over 500 of those measures are related to drug therapy, either directly or indirectly. So the key one we do, once again, that theme, we own adherence. We should own adherence. That we understand we can educate patients of the relationship of the drugs to their disease state. We can review their medications, identify possible side effects that might be. We can also help patients afford their medications, understanding the different formularies and therapies and possible availability in terms of assistance, whether it's through drug discount cards or assistant programs. Some of the different programs out there have been able to show this. One was the Wyoming Pharmacy Assist program. And basically, in this program, it was a collaborative agreement where residents who have concerns about their meds are scheduled with a one-on-one visit with a pharmacist. And when that pharmacist's role in that collaborative agreement was they looked for potential interactions, they looked for cost savings opportunities, duplications, provided pharmacy education relationship to disease states. And in this study, they showed that patients saved an average of $155 per month. The famous Asheville project, which occurred in the late 1990s, and the publications for that, and I have the references at the end of these slides, showed that pharmacists who became diabetes education coaches were able to reduce several different measures for the patients who were enrolled, who were employees of the city of Asheville. They showed a 50% reduction in sick days. Employers were able to save over $500 million in healthcare costs. And these pharmacists were doing it, right out of their community pharmacy. Project Impact was an APHA replication of the Asheville project, focusing on cholesterol. Once again, showed us very similar results. And there's numerous other studies out there that have shown that pharmacists involved in overall care help reduce that. I talked about in the prior talk these enhanced state pharmacy networks. This data has allowed us to come to this point. So the next question, though, is how do we get paid for this? We don't have provider status. Why would a physician want us to be part of this? Well, it is still in the building of clinical pharmacy services. It's the final frontier. It's the great frontier. How do we move ourselves from not just getting paid for a product, but getting paid on the medical benefit side? The easiest answer is that make us providers, give us a realm of what our scope of practice is, both on a national and state level, and allow us to bill for those services. That's the easiest answer, and that's the one we have to keep fighting for. And our argument of fighting of why do we need provider status, allow us to have a revenue stream that develops clinical services that are designed to help save the big healthcare cost dollars, such as hospitalizations and ER visits. But in the meantime, we have to take different avenues. Remember, whatever clinical service we offer, it has to be charged. Free is no longer. We've been very nice, and think about where has very nice gotten us by not charging for our services. Low reimbursements that are cut every year, and executives at PBMs thinking that we're not needed, the robotics can replace us. And enough's enough. And if you can see, it just angers me sometimes when I think about that. Think about any type of service that you use, any type of expert you bring in. Do they say, oh, yeah, we'll do this for free? All right. So it's important if you bill a Medicare plan like an MTM, all right, you need to provide these services at a certain rate too, because if not, it's considered Medicare fraud. So what is the future for billing for pharmacy clinical services? Well, there'd be the great fee for service. You can still always try that. Maybe patients will pay for that. There is ways through, initially under the Affordable Care Act, there was all these different things in the act to help pay for pharmacists. And there's been innovative grant studies to look at this, But unfortunately, a lot of that funding hasn't occurred. So once again, as we are re-looking at what our healthcare system is going to look like, we need to, as pharmacy, be right there at the table fighting for what needs to be done. Some other opportunities is we're going to talk about is that sometimes the manufacturers, for example, different educational services may be paid for different REMS programs. Manufacturers might be willing to pay for things such as insulin pump education. And some of those things you may be able to do without a collaborative practice agreement, but some of those may be able to go beyond that. Identifying state level needs, county needs, using that MTM model to develop that. And that's how we're starting these state pharmacy, possible enhanced pharmacy networks. Key thing when we're thinking about billing for a clinical service, we have to think of how does any other healthcare professional who bills for a clinical service, how does it work? Well, it works this way. Obviously, what you are reimbursed must cover both your time and expense. That's Economics 101. But what is billable time under most health plans? Billable time is really only the time you are with that patient or client that can be directly billed. Non billable time are things such as report writing, developing contracts, marketing, documentation. And so you need to, when you're developing whether or not this clinical service may have a good ROI, return on investment, what are all those costs that go into it, and is my reimbursement worthwhile? There's numerous possible ways that we could bill. One of those ones, if you're developing a service and maybe you're just charging cash, all right? I mean, there's nothing wrong with charging cash. People are always buying some type of service, in the newspaper, online, on infomercials at night. Why wouldn't they want to be able to? One of the possible reasons, because we've done stuff for free for so many years, people think we're always free. But you need to provide a value to it. What does it bring to it that somebody's willing to pay for that value? All right. One of those ways you can come up with a super bill of outlining what all type of services you offer. And some payers may require certain billing codes. One of the avenues that we've begun since MTM was created was developing documentation, is arguing to get clinical procedural terminology. The way all healthcare professionals have developed clinical procedural terminology is through CPT codes. Generally, sometimes those also have to be linked to an ICD, now ICD 10 code. But one of the things that happened with MTM was we did get 3 billing codes. The downside of these billing codes, though, is if you look at them in the Medicare book, there's no cost tied to each one of those. And the reason why is because we don't have provider status. But you could use these codes if you're setting up a contract with some type of entity, whether it's an employer group or whether it's a state group or a health plan. And these codes say the following. If I'm seeing a patient for the first time, the code is 99605. And so maybe that code, because it takes me longer to see the patient, maybe that code is worth $100. If I have to add additional 15 minutes, maybe I add, 25 to $30 to that. If it's a follow-up visit, maybe that reimbursement is not as much. And so depending upon what that is, I would use 99606, and 99607 is always for the additional 15 minutes. And so the way these billing codes are set up, this is how physicians, and I'm going to show you a couple more billing codes here in a second. When would an MTM CPT code used? Well, according to what the manual says, is when there's a face-to-face, all right, or a telephonic interaction where there's a patient assessment and intervention done. Think about the components that go on into an MTM. All those are part of that CPT billing code. If you've ever done Marixa for MTM, when you go to bill, you'll notice that those CPT codes are listed there. Another opportunity with collaborative practice agreements, it's what's called incident to bill. Physicians may bill for non-physician services through the use of incident. So, for example, codes may be used for pharmacists delivering services in a physician's office. And there's specific criteria on how to use those. And I provide that the Pharmacy Service Technical Advisory Coalition has some great resources. CMS.gov Center Pharmacist has also some great resources of how that can occur. And billing for incident to physician services is an option. The downside is a lot of times the pharmacist has to be residing in the same building as that physician. So it's not an option if we're at the community pharmacy. This is where the only way this becomes an option down the road is if different rules and regulations are written. What are the rules and regulations of technically telemedicine? And so a lot of these things still need to be answered. But once again, this allows a physician to bill for services provided by non-physicians, granted that specific criteria are being used. And what does that criteria for use mean? That the service must be an integral, although incidental part of the physician's professional service. It's commonly furnished in a physician's office. Is under direct supervision of a physician. Now, there's incident of two billing codes that sometimes may not require direct supervision. The difference is they're not always a high reimbursement. And the other last one is the provider must be a contractual worker. And so how we would get paid, maybe not necessarily for each incident, but you would look at how many incidents you hope to be able to have billed, and you come up with a fair value of how you're going to get paid in contract. At the end of this article, I provided a good reference. It's several years old, but it was a Jaffa article of pharmacists who are actually working in an AM clinic down in Nashville, North Carolina, and they're billing for incident. And so here's some different types of billing for cognitive services: anticoagulation, osteoporosis management, pharmacotherapy wellness. And here are the different types of codes. Here's the timing of that's involved in those. And here, now this is based on North Carolina Medicare reimbursement, and this is several years old, but here are some averages of what those reimbursements are. And if you take a look at those averages, they're not too shabby. If you think about how many scripts you got to fill when you think about what is your net after, and these are not showing negative numbers when you bill. The only way it's a negative number if you're not utilizing your time and you're not developing. Before you develop a collaborative practice, you kind of got to develop a business plan of what is all the procedures that go on in this clinical service. The next two slides are actually something that several of us that have been working on, especially at the state level, is looking at what are the different billing codes that pharmacists could contribute that are under billing for incident. And if you look at, there's our classic medication therapy management. There's the diabetes self-management that I talked about. All right. And one thing I didn't mention in the first talk, I'd like to just re-mention about diabetes self-management, is the key way for pharmacists to make money and be able to offer this service and not to lose money. Maybe not to say make money, but not to lose money, is that, hopefully make money, is that you do it in groups. Most people that do diabetes education don't do one-to-one education. They do it in group education. Notice another one is incident for physicians for transitional care. And one of the things that a lot of these transition care programs that pharmacists have been involved in is they're doing the 48-hour phone call where they're calling the patient, doing a med rec, seeing if there's any changes. And that is something that physician offices just don't always have the time to do. In fact, they spend more time when the patient comes in because they're doing a med rec and trying to figure out what they're on in their discharge. If somebody provided a service where they're doing this call ahead of time before they see the patient, then this is an opportunity. And where incident transitional care is, it's for high-risk patients that are potential readmission patients, and these patients have to be, based on the complexity of their disease, seen by a physician with 7 days to 14 days. However, with each one of these, there has to be a 48-hour phone call. Other areas is annual wellness visits. A lot of times there's physicians that just don't have the time to do this. There's numerous pharmacists that are doing this. And another key one is chronic care management. And this is our newer codes. And chronic care management is at least 20 minutes of clinical staff time directed by a physician or a qualified healthcare professional per calendar month with the following required elements: that the patient has multiple two or more chronic conditions expected to last at least 12 months or until death. And basically, this is reimbursed providers providing specific non face to face services, that these are focusing in diabetes, heart failure. And when you read more into this act, if you pull it up, it mentions pharmacists, although we're not providers. And so this is a good area that maybe pharmacists could get involved in doing that. Chronic care management. The other confusion that we need to be relayed, that is, if we do eventually get provider status, or if we're working for physicians, that this billing is a lot different than the NCPDP billing that we do for prescriptions. This billing goes under what's called the X12 standard. And so if you're looking down the road to maybe develop or purchase a software that may interface with your pharmacy system, if you've ever gone to the NCPA show, there's several software companies out there. I just sat in one last week from a company that's down south, and they are looking at how they can provide documentation to pharmacies within their pharmacy that interfaces with it, that'll eventually interface with electronic health record. And this is a big thing. This is a big push. And so talk to your pharmacy provider, your pharmacy computer service next time, and see what they're doing down the road, or who are they partnering with to allow pharmacists to maybe be able to document. Because the key thing too, when it comes to billing for incident or doing these collaborative practice, is not just writing the collaborative practice agreement, but developing the documentation system that is needed and what information will be collected that for billing. Because where physicians sometimes get shy, if you're not attuned to what this billing and documentation is, they may not want to partner with you, because the biggest thing they can get is an audit, just like we cringe when we get prescription audits. And when they get Medicare audits, they're looking, are they documenting exactly what they're saying, and and what needs to be asked during certain types of visits that are billed as billing for incident. Obviously, where this gets billed as X12 is actually an extension. If anybody remember the old, what we call the HCFA 1500, and it's the CMS 1500. Because if we're talking about Medicare billing, where we would be billing for incident, where we're hoping for provider status, is the ability to bill under Medicare B. And Medicare B is where we're hoping, and that is on the medical benefit side. And so, like I said, if we're ever going to get paid for clinical services, it's probably not going to come from the PBM side. It's going to come from the medical side, the Medicare Part B side. And this is just, if you ever looked at a CMS 1500 form, there's an area where you'd put your CPT codes, your diagnosis codes. And like I said, this is pretty much done electronically. A great resource to learn about all these different billing codes, once again, is that Pharmacy Technology Coalition, and there's a link to their website. Another key thing to think about is, as we're trying to push for provider status, we all know what an NPI number is for a pharmacy, but you can actually go online right now and get your own NPI number. And I tell people this all the time. I tell students this every year, that when you graduate, go ahead and get your NPI number. I've had an NPI number for probably going on almost 10 years now. I've never been able to use my NPI number, but why we keep pushing, telling pharmacists to go get this NPI number, is as we keep pushing for provider status, we keep showing, look at all these pharmacists out in the workforce willing and wanting to be able to offer clinical services. So some tips for billing is that, if sometimes there may be avenues with certain private insurances. I've heard stories where in different states where pharmacists were able to get contracts with private insurances to do diabetes education. And that's the purpose of these pharmacy networks, is they're trying to do this negotiation with you. But you want to find out things such as patient eligibility, how is the MTM services to be billed, what is the documentation required for that. So, the one key thing that I hope you come away with this is that the challenge is, besides developing the written agreement, you have to write the patient care protocol. So exactly what are you going to do? When you see a patient for a diabetes program or you see a patient for anti-coag, what are you going to do? So for example, in an anti-coag clinic, I'm going to see the patient. I'm going to get their INR. I'm going to ask them questions about, you know, I'm going to ask them questions about, what's their diet like, any new drug therapies. And so you want to enter all those different protocols. The other thing is delivering of your service efficiently. Many third-party payers pay a set fee, and so once again, there's only that billable time that you can see the patient. So incorporate technicians helping set up appointments, maybe collecting that information. Think about when you go to see the physician, all right? You know, when do you see the physician? Usually the very last step of the thing. Somebody's doing heck, sometimes you just get a clipboard and you do your own intake form. And usually there's a nurse or a nurse technician who does your blood pressure, takes your vitals. So think about how you can incorporate pharmacy technicians and support staff. What technology? Talk about your pharmacy system. What can you incorporate into your documentation system? So, in summary, a collaborative practice agreement, there's many components that go into it. There's the introduction, there's the description of your service, there's how you're going to recruit patients, there's the consent form. What are the protocols you're going to provide? What is the forms of communication to the patient and the physician? What outcomes will be collected? And not necessarily reimbursement. Remember I said you're not allowed to provide incentives, but if there's a billing component, that component should be described between you and that physician of how that's going to occur. And then definitely you need your license numbers and your signatures, the pharmacist and physician. So think about these thoughts. Is there a potential for a collaborative practice agreement in your area? Who could be that person that you could partner with? Who could you identify, a physician or practice, to try this? What are the barriers for establishing this program? Do you think that I just can't do it because I don't have the education? Every one of you is smart enough to do this. But finding out what information do I need to do to get it done? What do you think are the challenges? And so think to yourself and reflect and write those down. I did provide a sample. I'm going to be providing on the website a sample collaborative practice agreement, and this is one from an asthma clinic. There's some statements about the Pharmacy Act making this legal. You would list your parties that are involved. You would list the disease state and the scope of practice being co-managed. You'd have the effective date, who's the patient population, what are we allowed to do in terms of medication ordering. Notice the 72-hour window here. What are we allowed to do in lab monitoring? I think it's always good, too, to put what this protocol does not cover. I think it's a good CYA for you from a liability standpoint. What are the pharmacist responsibilities who fall outside of this protocol? What occurs? And so here's an asthma one talking about what's at the initial visit protocol, what happens at the follow-up protocol, what's the communication, and then an area for the signature of the pharmacist and the physician. Here's listing the responsibilities of the pharmacist, the responsibilities of the supervising physician, the agreement of the two parties. Notice here's the 2-year rule, and the signatures. And then you can always add appendixes. Here's an appendix of all the different assessments of asthma. A lot of these come right out of the clinical guidelines. If you Google collaborative practice agreement for pharmacists, you're going to find many different resources. But anyways, this would be an example of a collaborative practice agreement. If you go to the PPA website or just type in PPA Toolkit Collaborative Practice Agreement, there is lots of different things on this webpage. Laws and regulations of collaborative practice agreements in Pennsylvania, liability insurance, several different examples of collaborative practice agreements for you to take a look at. Okay? So, I do have several assessment questions. You can look at the handout here, but during the live session, Greg Drew will be reviewing these, and at the very end of this assessment question, there's actually a reflection question for you to think about as we talked about. Thank you very much.